Welcome, everyone, to the Four Eyes podcast, brought to you by Young OD Connect. We give you a clear view into the young optometry world across Canada and the US. And we are your hosts. I'm Dr. Amrit Bilku.
And I'm Dr. Deepan Kaur.
And today we have Dr. Sophia Leung, and she practices in Calgary, Alberta, and she is all about the cornea. Sophia, do you mind telling us and the listeners just more about yourself and how you became an awesome superhero for the cornea?
Yeah, so I graduated from University of Waterloo, and then I actually did about 5 years in private practice at first, just kind of getting the lay of the land, trying to figure out what I wanted to do. And I joined the board, actually. I joined the Alberta Association of Optometrists when I was in my second year and got to see kind of the trend of optometry. And there's a lot of discussion about, the expansion of scope and the medical movement, all these things. And I decided to pursue a residency. So I went down to Oklahoma and I did an ocular disease refractive surgery residency down there, and I did an extra year. I did a clinical fellowship there as well, and that was in advanced glaucoma and cornea, which became kind of my two loves. And so they gave me sort of an opportunity to pick the areas I wanted to do, and I kind of liked both the optic nerve and the cornea. And I realized that, of course, if you're treating glaucoma, you're going to be treating the cornea at some point. So I was like, why not just bundle that in there? And it became more and more fascinating the more I learned about it. And so moving back to Calgary, I started to work with an ophthalmologist who specializes in cornea, a cornea surgeon. So my practice now is basically a secondary and tertiary referral practice. I have an optometry-centric referral practice. And yeah, most of my days are looking at misbehaving corneas, which I love. So
Those pesky corneas.
they can be, yeah.
Now that you're working side by side with ophthalmology, do
Yeah.
you ever prescribe glasses anymore? Is that even a thing?
No.
Or
So no,
you
not at
remember
all.
how to refract,
Yeah,
Dr. Leung?
yeah, it's a little fuzzy. Yeah, it's a little fuzzy. No, not really. And one of the reasons that was actually a strategic decision, because one of the things when you're trying to build a referral practice, especially when you're trying to build it to be optometry centric and making sure that it's supportive and not competitive in any way, I decided to actually pull out of primary care in terms of refraction dispensing altogether. And because I wanted to really make sure that there was that support there, because whether convenience, whether it's, the trust piece whatsoever, I didn't want any patients that were going to come and see me for any secondary care to effectively stay in an area that I wouldn't be specializing in. And I say that because I do actually believe that primary care could actually arguably be its own specialty, and it should be, because we should know how to do primary care well. And refraction, myopia management, all these things that is part of that day to day. And so, no, not at all. I've been out of the refractive and kind of the contact lens and glasses world, the technology. Every time a patient asks me, I'm kind of like, you know what, the experts are out there. They're in your primary eye care provider's office.
Yeah.
Please go talk to them, because I have not been keeping up with that. And same thing with kind of pharmaceutical industry and meeting the reps and being on advisory boards. I get a chance to be able to interact with them a lot. But no, the technology around the glasses side of things, there, and with all that's coming out, it's really exciting to hear. But I'm not in the know as far as those go, so I rely fully on my colleagues for that.
I love
It's
that
interesting.
though. I do the same with BV referrals. Like, I
Yeah.
still offer primary care, and if there's any BV referrals, BV involves a lot of refracting, but I
Right.
don't dispense. I send that RX back to the referring doctor, and I'll let the patient know that is your primary care doctor, your everyday eye care, person. That's where
Yeah.
you get your glasses from. And I do see a huge shift in how many ODs are now trusting me with their patients, and that referral relationship is really strong now,
Yes.
because it shows that we each have our own strengths in what we can do, and the patients are actually happier to
Hmm.
see multiple doctors who will give them the right care that they need. And I
Yeah,
think more ODs need to really be aware of that and hear that more often, because
for sure.
once you know and you have a good relationship with an OD like that, you'll never
Hmm.
go back. And I
And
was gonna
it's
say,
not
Deep
sort
on,
of
she moved on up because she's got technicians to do that for her. She doesn't need
Well,
to use her bare hands anymore to
yeah.
send those
but
lenses.
like like in school, you kind of learn how like refraction as an optometrist is kind of like your bread
Your
and
bread and
butter, right?
butter.
So like it's just interesting how now our professions kind of a little bit moving away from it. Like
Hmm.
not completely, obviously, but there's still some opportunities there. Do you miss
Hmm.
it at all, Sophia? Or are you
Yeah,
kind of like,
you
no,
know,
this was not really my thing? Because there's some optometrists that are like, I want to specialize and do this all day and
right.
not do the primary care, not refract.
Yeah.
I'm not
Yeah.
interested in that. So
Yeah.
I don't know.
So it depends a little bit on kind of how someone might see, the point of primary care and refraction, right? Like
Mhm.
for me personally, I just love ocular disease so much that I knew that I was calling away, to it. And I had a conversation with a friend of mine who owns a primary care practice, and she actually said, there's actually something very valuable in doing primary care well. This is
Mhm.
actually going to be your front line. You are caring for these patients in terms of their day-to-day needs, right? And so there is actually a huge need for it to be done well. And what I do miss about primary care is actually the time that I get to spend actually building rapport and better relationships with the
Yeah.
patients. Because
Nice.
I see about 40 to 60 patients a day. I have a scribe that helps me.
Wow.
That time, I mean, how you get these quick connections, but you're not able to hear about their family. You're not able to be able
Mhm.
to say, hey, how is, so and so, and these things. And I see some of these patients, I do see a lot of them, almost monthly because of, changing a contact lens on a really bad NK, those kind of things. So you get to build rapport with them that way. But it's not the same. It's not the same
Yeah.
as that direct rapport that you get in primary care. So I do miss that. But from a standpoint of me personally, my personal interest, I think, has always been in ocular disease, right?
Yeah. Mhm.
But kind of to your point, I read about the idea of intra-professional referral is
Mhm.
so key because um, you really can't be good at everything. There's so much going
Yeah.
on all the time. And so it's kind of like one of those things where in school, we're taught to do everything, right?
Yeah.
And I think that the traditional business model around eye clinics right now is, yeah, you're going to make most of your revenue through dispensing. And I think that's what we're taught. And that might be just the nature of how maybe optometry is a little ingrained in that traditional
Hmm.
business model, but it's changing, right? You see that
Yeah.
there are, like yours, I read about, the vision therapy sort of binocular vision specialization is kind of broken out, I'm assuming, in different revenue
Hmm.
streams. And you also will have, let's say, dry eye clinics and, eye care aesthetics, and those are all kind of branching off into different,
Yeah.
areas now. And so I think there's still a huge role to play for primary care. And I think that people do need to be passionate about it. If they're only doing it because it's a moneymaker, I would argue that maybe they should maybe reassess why they're doing it because
Yeah.
it's going to
Mhm.
come out in their patient care, right? It's going to show up
Yeah.
when you're talking to your
100%.
patients. If you don't care about it, if you see it just as, a bottom line thing or, what's my chair time costing me right now, that's going to leak out and people can
Yeah.
feel it off of you, right? And so whether you're doing a 5-minute assessment in, a corneal practice, or if you're doing a 1 hour, vision therapy assessment with a child that can't verbalize what they're experiencing, or whether you have a
Hmm.
30-minute, 15-minute exam, all of that really comes to, do you care about what you're doing, right? Because
Yeah.
if you care, then the patient will respond to that. And I think that's
Right.
probably more important than trying to pick what is going to be my biggest revenue generator. I'm going to run to that. It's like, do you care, right? At
Yeah.
the end of the
Yeah.
day, do you, and maybe short term, it might be okay to be able to say, okay, I made some good money today. But the long term, look back and like, was that valuable use of my time? Am I happy with that? You have
Mhm.
to wrestle with that, right?
Yeah.
Man, Sophia, we can talk about that all day. But you know what? I won't comment on that because there's something
I
because we
think,
have to we have a
yeah.
time limit on this episode. But I
Right.
will I agree with you. There are many ODs out there who want to dabble into specialty just because they think
Yeah.
it's a revenue generator for their practice. And
Yeah.
sure, you can totally do it. You can also hire someone to kind of kickstart it, whatever. But
Hmm.
I think the day that that person is going to struggle, if they're not passionate about it and they're not learning a lot about it, is the
Yeah.
day that they have to troubleshoot and the
Yeah.
day that that specialty service is not working out for a patient.
For
They
sure.
won't know what went wrong, how to fix it,
Yeah.
why it didn't work.
Yeah.
Mhm.
There, yeah. Um, those are my 2 cents. Those are my 2 cents there.
I
Yeah.
think, yeah, like we've always talked about burnout too in our
Yeah.
profession as well. I think if
Yeah.
you're doing something like exactly what you said. Like if you're just doing it for the money and you're like, okay, what's my chair time? Like this cost me this much. Like how long is
Yeah.
this patient going to be here?
Yeah.
Um, I think, yeah, you have to kind of self-reflect and be like, do I really want to be here? Do I really want to do this every
Hmm.
day? Like maybe I
Yeah.
just need to take a break.
Yeah.
But even like your mode of practice, like what you're doing is not common in Canada. Usually when graduates or new grads come here, it's like, okay, private practice,
Right.
or corporate setting, primary
Right.
care. Yeah, we
Yeah.
you can dabble in dry eye, you could dabble in vision therapy, but
Hmm.
there's still that like dispensing part that's important. Do you
Yeah.
think there's going to be more opportunities like what you have in Canada? Because there's lots of these kind of positions in the States, right?
Yeah.
But we
Yeah.
don't have a lot of this kind of practice in or this practice mode in
Yeah.
Canada.
Yeah. I hope so. I think there's a huge need for it and value. The referral pathway that I started took off really quickly, mainly just because when you have a wait list to, the surgeons and tertiary care, and it's, going to be 6 to 9 months, and you have someone who isn't the same day, it's not going to need on call, but maybe in a week or two, there is a huge, there's huge need for it. But I think there's a couple of different areas that have to kind of fall into place. The political climate, of course, as we all know, it is tense sometimes, right?
Hmm.
Especially when things like, scope, for example, is on the
Hmm.
table. But historically, also, I think there can be a little bit of a misconception of what each profession can do. I think there's a general misunderstanding still by any of the O's towards each other of
Yeah.
what actually can be done. And so if a new grad were to try to approach, let's say, a surgical practice that has never had optometry before, it can be a very bumpy road.
Yeah.
I think that I kind of landed in a bit of a right timing sort of thing. There were an optometrist that was kind of the lead optometrist on the refractive surgery side who had sort of prompted for the surgeon to say, hey, like Sophia's coming back and she's going to have some more training. Maybe kind of keep an eye on her. And there were some other optometrists at that practice that tried to make something work, and it really kind of they ran into some issues there. So it kind of was like a bit of a perfect timing in a way where I
Hmm.
was able to step in and kind of say, okay, this is what my training was like. This is what I practiced in for the last 2 years, and this is what I can do for the clinic, as opposed to having to
Nice.
figure it out. So
Yeah.
I hope that there would be more, but it takes, I think, the willingness of, let's say if this is an ophthalmology practice, for example, the willingness for an ophthalmologist to try something different, right? To
Hmm.
to risk a little bit of bumpiness to try something different. It also requires the optometrist to be well trained because they kind of have to hit the ground running. There's a lot of, unfortunately, these sort of ideas that if I can just get in, it'll be like a residency. I'll learn as I go. But these surgeons have no time to
No,
teach, and that's where a lot of the
absolutely
breakdown
not.
becomes. Is that they're not going to able to coach you through that because your role there is to be able to offload their patients. So they're not going to double up and see it. That's making more work for them. And I think that is one of the biggest reasons why I think it fails is because there's this expectation there's going to be coaching and mentorship when as much as they would maybe like to do that, there's no time.
Yeah.
These volumes are these clinics are bursting at the seams. And so
Mm-hmm.
you kind of have to ready to hit the ground running. Um,
Mm-hmm.
the other challenge is that there's not really a strong, like you said, Deepon is not, it doesn't really exist. So I kind of had to step in and say, okay, we're gonna just try to figure something out. And my first 2 days, I was doing Goldman checks, and I didn't even have the authority to change prescriptions. So I literally
Wow.
sat there with tonometry probes and did 50 Goldman checks, and I was like, I got an advanced glaucoma fellowship for this, and it was
Oh
brutal.
my
And it
gosh.
takes time to find, trying to, figure out it. And there has to be trust, right? For me
Yeah.
to be able to
Hmm.
stand by the surgeon's work, for the surgeon to be able to offload his patients and say, I'm not going to see these patients who are in tertiary care. There has to be a trust and rapport built up. So for good reason, there has to be this sort of mutual vetting of each other.
Hmm.
And sort of my advice for anyone who's looking to try to break into that, really pick a surgeon that you can stand by. There's going to be a lot of ophthalmologists, a lot of surgeons who can see it because they can see the business model, they can see how much money that they can make off of
Hmm.
this, but you absolutely have to work with someone that you can stand by their work, right? If you
Yes.
wouldn't bring your own family member to come and see you and then, as an extension, see that surgeon for surgery, really take care as to whether you want to be there or not. Because at the
Hmm.
end of the day, you are going to be at you're going to be representing that clinic. You are going to be defending the surgeries to some extent. If you have a
Yes.
post-op that's gone,
Hmm.
awry, you better hope that you'd be able to say confidently that this was truly one of those, post-operative complications that was, not because of surgical work, right? It's not because
Hmm.
of poor work. So your reputation, your
Yeah.
brand, I guess, if you will, also kind of your ethics can be on the line by choosing the right people to work with. And so sometimes the more conservative surgeons might say, you know what, let's wait and see, and it might take a bit longer to build that. Or you might
Mhm.
have someone who's a little bit more progressive, I guess, if that's the right term, to say, let's try it. But you really have to make sure that you don't jump on just whatever opportunities in front of you. Really assess the work that's happening behind the scenes and behind closed doors to make sure that you can support that.
Mm.
Yeah, I
Interesting.
think definitely find a, for anyone who wants to work in a ODMD, sort of a surgical practice, make sure again that that OMD is not looking at you as just a, revenue generator for their practice. Like make sure that
Right.
they also actually care about the optometric profession and that they
Right.
do respect you as well and they don't think that you're also just going to be a technician
Right.
Mm.
who's checking the refraction, checking
Yep.
tonometry and, doing your paperwork.
Yeah.
So that's really important. So it makes you feel valued too, right? And
Mhm.
you kind of just dabbled into what your first couple of days were like working in
Yep.
that sort of a practice setting. But Sophia, what is your typical day-to-day like in a, cornea heavy surgical center? How many patients do you typically see a day? What sorts of conditions are you running into on an everyday basis?
Yeah. So average right now is about 40 to 60. If I'm also covering for, another ophthalmologist who's there with some of the post-ops, it can go up to 80. But those are crazy days. So I don't really like those. I was doing
Wow.
them for a little bit and I was like, I can't do this.
Okay, it's good
Um,
you have a scribe
so
because I would not finish all those charts.
yeah, a scribe is key. Oh my gosh, they're valuable. But yes, having a scribe definitely helps make that possible. If I didn't have a scribe, it would be near impossible. I mean,
Oh my gosh.
it's I was, and I didn't have a scribe at the beginning, and I was seeing about 30 patients. I was hours behind, right? And so you're just
Oh.
it's learning a new system, all that. So, but yeah, so 40 to 60 patients right now, mostly problem specific, and then even with the new referrals that come in, they're comprehensive in the sense that I'm looking at everything from a health perspective, but I'm not doing a cover test, not doing
Hmm.
any of that. That actually is all delegated. So basically, our technicians will basically do a lot of that, and then I might recheck a few things, especially if there's a palsy in suspicion. But for the most part, a majority of the cases that I see are going to be really any corneal condition, ranging from a dry eye to limbal stem cell deficiency, a lot of herpes, a lot of microbial keratitis, fungal, acanthamoeba, the works. We had a pseudomonas one that I saw a couple of days ago. A lot of bad NKs. That's kind of become a big practice builder, I guess, if you kind of had to say. A lot of referrals coming in for these ones that are just not healing. Patients are, not getting better, but they're not really having any issues. There's kind of that tension of they're not willing to do the treatment, all these things where sometimes you just need someone else to say, yeah, you have to do the medication. A lot of cataract consultations. Obviously, we're still a referral practice for surgery as well. So I do the initial triaging for the cataract side of things, keratoconus as well.
Mhm.
Yeah, so kind of the works and kind of some odd ones that kind of come in randomly, and I guess some neuro referrals as well too. But yeah, a
Cool.
majority is going to be anterior segment and cornea, about 80-90% for the most part.
Wow.
Mm.
I love that.
Oh,
Yeah.
I didn't realize you saw the cataract referrals too. Because when
Yeah.
I do send a lot of referrals
Yeah.
to SEMA
I
Eye
see your
Care
name.
Center. Oh, okay.
So
I
you can
wasn't
write in
sure if
your
you saw.
referral. Hi, Sophia.
Yeah, a
Yeah,
little wave down the air.
I know. I didn't know that you saw those two. Oh,
Yeah.
okay.
So
Well,
we
that's
kind of changed it a little bit because for a little while, we were running into some issues that was brought up by referring doctors, as it should have been, that patients were going in, getting slammed with information, and not really clear what exactly their choices were. And so optometry, having, one of the strengths of optometry is bedside manner and patient counseling, right? Basically, I mentioned to the surgeon that I'm working with now, the residency that I basically came from whole year was high surgical volume, like cataract, oculoplastics, basically just a high, heavy surgical center. So we changed it a little bit so that I would see the patient initially to screen for any dry disease that we can help manage, check on whether there's anything else going on, but really kind of have a discussion and a little bit more time to talk about cataract surgery, the implant option, just a real sort of still quick, but sort of a briefing about some of their options so that when they then see, let's say, the surgeon directly and he mentions this lens and that lens, they already kind of know, they've already been thinking about it.
yeah.
And then when they see the IOL technician for the measurements, they pretty much are ready with kind of what their choices are. And now we just have to figure out what lens type is going to be most appropriate for their specific measurements. So it made it a lot easier. And it allowed actually a lot more triaging of patients who actually didn't have cataracts at all. We get a lot of referrals from GPs and come in, and it's a
Oh,
lot of times it's not cataracts at all. We've caught a plethora of retinal diseases, a lot of corneal problems, and things that's like you just have presbyopia. Like I'm going to connect you with an optometrist, and those kinds of things. So having that
Yeah.
in place really has freed up. I mean, we're still very, very busy, but just kind of taking a little bit of that surgical volume off of the unnecessary triaging, off of the surgeon so that he can actually
hmm
get more patients through. And that's ultimately the goal, to be able to get better access and faster triaging for the patients.
Yeah.
This is actually a random question. Those GPs that do send over referrals, do you guys
Yeah.
ever write letters back saying perhaps an
Yeah.
optometrist would be a good
So what I actually
suggestion
do,
yearly?
yeah.
Yeah.
So what
Yeah.
I actually do in those cases is I will, especially if that patient is not connected with an optometrist already, or if they are, I will write my letter to the optometrist and CC the GP. So that is
Okay.
Okay.
basically me saying this is their primary eye care provider. They should be triaging this, especially when it's either a borderline cataract case, especially when it's
hmm
like not quite surgical. I try to loop them back in with their optometrist or refer them to whoever's closer to their
Hmm.
postal code or whatever, and make sure the family doctor is aware that
Ah,
the optometrist needs to be at the center point of this. And so,
okay.
yeah, a lot of letters very subtly be like, hey, like, go over here.
Yeah.
Yeah. And some of them just don't know, right?
Yeah.
How
Yeah.
how are they supposed to know? You do a vision check and you're like, oh, you can't see, maybe his cataracts are at the right age. And I think a lot of times the family doctors are also, we talk about, the burden of patient volume, right? They're
Mhm.
slammed with everything. And a lot of family doctors, including, whether they're familiar with optometry or not, they only get about 2 hours of
Yeah.
training with eye care,
hmm
right? And
Yes,
so
that's true.
unfortunately,
Yeah.
it's a lot for them to triage. And so I don't fault them for referring over. They just kind of, if there's a pathway already established or maybe a rapport there.
Yeah.
But a lot of family doctors that I write back to are fairly receptive as far as kind of I've been hearing, they just
That's
realize they
great.
just need to be shown what the different referral pathway is, and it's not really a big issue. But there's still, I think maybe a shout out for kind of maybe more advocacy or self advocating for kind of your
hmm
patients. Anybody who's listening who works near family doctor's practice, doesn't hurt to pop in there and say, hey, introduce yourself, because you'd be surprised. That in itself is a really strong referral builder, because these patients need to be seen.
Yeah.
A lot of them are
Yeah.
going through
N-
and they're not
Yeah.
connected with an optometrist, right? And so, yeah.
No, you know what? That is so true. I'm glad you're bringing up so many things, Sophia, that I'm like, you know what? We can have a whole nother episode about
Yeah.
these different
Yeah,
things.
for sure.
That applies for, yeah, any young OD listening. Like if you really want to start getting a referral base out there, you're
Yeah.
so right. GPs, they might not be well educated in, what optometry is versus ophthalmology, right? They just think you have an eye problem. Where's the
Yeah.
eye doctor? Send you off because I
Right.
only have 5 minutes to deal with all of your health problems too.
Right.
And I've seen that where at Northern Site we've given the local, walk-in clinic just a simple referral sheet to say,
Yeah.
hey, where the eye doctor is closest to you, here's a referral sheet, check off whatever eye problem it is and send them over.
Yeah.
They have been sending patients over nonstop for
Yeah.
any condition. I think they're going to be more than happy to do that because
Yeah.
in the US and Canada, I mean, the healthcare system is so burdened. Family
Yes.
doctors are drowning too.
Yeah.
Yeah.
Yeah, I think they'll be more than happy to send
Yeah.
send over to whatever eye doctor kind of
Yep.
shows up on their
For
desk
sure.
first.
And pharmacists too, right? Now the pharmacists, at
Yeah.
least in Alberta, are being burdened with doing essentially like walk-in triaging, right? And
Yes.
nurse practitioners, really anyone who might be having to field these cases,
Hmm.
never hurts to stop in and make that referral pathway as easy as possible, right?
Yeah.
A lot of provincial associations do have like tear off kind of, like you said, like the post-its, right? Or whatever.
Hmm.
Just make it as straightforward as possible. A lot of times people just need to know where to send it.
Yeah.
Yeah.
So, Sophia, you mentioned earlier that you did your residency in the States in Oklahoma. And
Yes.
actually, it's really nice to speak to someone who did their residency after practicing
Yeah.
for a couple of years, right? Out in
Yeah.
the real world. Can you just tell us, what was that experience like going from
Mhm.
practicing full time to becoming a residency student?
Yeah.
Kind of
Yeah.
going back into that student kind of mentality.
Yeah.
And was it worth it? Or, what like is it necessary to do a residency if you want to specialize in anterior seg and corneal disease?
I would say that before I went and did a residency, I was told by many colleagues, 5 years seemed to be the magic number, 5 years of practice, and you'll see as much as you would need an equivalent of residency. And
Mm.
um,
Mm.
I would say I did that, right? 5 years of private practice
Hmm.
went down to residency. I would say they're not equivalent, unfortunately. When especially if you're looking at and maybe it differs in terms of what kind of specialty and whatnot, but I would say in terms of corneal disease or a certain ocular disease, I think it's very, very different. Now, it depends on maybe where your 5 years of practice would have been, perhaps.
Hmm.
If you
Exactly.
spent 5 years working at like Oklahoma Medical Eye Group where I did my residency, if you spent 5 years as an associate practicing there, you will get your residency, basically,
Mm.
because you're going to be seeing those kind of cases
Yeah.
constantly,
Yeah.
right? But to get a position there, you would have to have a residency. So it's kind of this sort of
Yeah.
cycle that you're stuck in. But one of the most eye-opening things for me when I stepped into the residency, so the residency actually, I didn't do it at a school. I did it at a private practice, and one of the reasons was because, well, I've already been in that private practice lifestyle. I didn't want to kind of be like full-on student again.
Hmm.
And I picked a residency that was able to tailor the program to me, and that's really important. And I would say that for anyone who's first of all interested in going to a residency, you have to choose the right fit, and that's really crucial. There's lots of residents out there; they're not all the same. But these are going to be, you want to be able to see the cases that you're going to want to learn under someone who's had ample more experience than you that you can actually get along with. Because nothing worse than spending a whole
Yeah.
year with someone you don't get along with, learning something you're not really wanting to. What a terrible way to spend a year. It's not worth the money,
Yeah.
right? Um, so I would say because of that, I chose a really good residency program and matched to one that really fit me. I think that learning experience for me was very different than having spent 5 years in primary care. The other thing that was really eye-opening, I remember seeing this really bad corneal case. It was like this, I think 100 micron thin cornea about to perf, and I was like, neat. And they drafted this
My
beautiful
goodness.
letter, this referral letter, and I go to my residency supervisor, and I'm like, okay, I'm ready to refer. And he's like, okay, like take that, change the name at the top, write your own name. And I was like, why? And he's like, you're on the other side of the referral now. And he's like, you
Yeah.
aren't going to be the one, like, is this a corneal surgical case? And I was like, not yet. And he's like, well, that means that that's going to be on you, right? Our role here is to essentially do the medical, non-surgical work so that the surgeons can stay in surgery. And that was like a switch of perspective for me that I was like, okay, I have to think differently now. And that forced me into thinking more deeply into the disease process because I'd have to figure out what
Mhm.
was going on from a different angle. And that switch was crucial. And it's there are still days where even today, or not today, but yesterday, I was looking at a case and I was like, I don't really know, and this is probably going to be an evisceration case, but let's just chat with some colleagues, right? And so there's still times where I won't know. But that was a very pivotal change for me to see it differently and having that mindset going into now learning all these cases. So to the question of do you have to have a residency? Um, I don't think it's absolutely necessary to
Mhm.
specialize. I do think that it is possible to specialize or at least build a practice without it, but you have to commit to learning, and that's probably more important than anything, right?
Mhm.
There really isn't a residency for every single specialization, right? Arguably, for VT, for example, right? There's actually a lot of really strong courses and programs that you can go to that will get you there. And arguably, one could actually do that and be stronger in it than going
Yep.
through a residency. So not every residency is going to be the same. Not every area of specialty is going to be the same.
Mhm.
But it really isn't anything to replace essentially being in the trenches doing this essentially every single day, as opposed to
Yes.
having this mixed bag of cases. And unless you're at a primary care clinic or a private practice that's already specializing that and that's
Yeah.
all
Yeah.
you see, then arguably, yeah, you could do that. But the residency, the point of that too, I had a mentor tell me, the point is also is to be learning from someone who has seen amples more than you
Yeah.
and forever will have more experience than you so they can teach you what they know, as opposed to you
Yeah.
kind of trying to figure it out on your own, and that'll accelerate your learning. But for the people who are not going to do a residency, let's say it's not feasible, let's say it's not reasonable for you to move for a year, right?
Mhm.
Um, for that, I would say commit to learning at the highest level you can possibly get. And that might mean going to shadow people that are doing it more often than you, that are seeing these cases
Yeah.
every day, because you absolutely need to learn from people who have seen it before you. But if you are going to go into specialization without the residency,
Hmm.
then you are going to be a forever learner in it. You need to be chasing kind of the most highest level and learning from that almost daily. And
Yeah.
so it will be harder to do. You can do it, but I think the difference in what I've found in the people who speak on their expertise and speak on it well are the ones who have never stopped learning, even if they did residency or not.
Yeah.
They are the ones
Yeah.
that are constantly learning. They're looking at what papers are out there. They're talking to researchers. If you're going to academy, for example, you're going to the posters and
Hmm.
asking about it. You are digging, and because if you're going to be a specialist, you are digging. You're not going to be able to download the information off of an op-ed and be like, okay, now I know it. You are going to be the one writing it, right? And
Yeah.
so those are the times where if you're committed to learning it and you're willing to put in the grind and to do that,
Yeah.
then absolutely you can.
Yeah.
And you may not need a residency for it.
Mhm.
Yeah, actually, in terms of education, yeah, if someone is not, wanting to do a residency for any reason, what specific conferences or resources do you recommend people look into to learn a
Yeah.
lot more
Right.
advanced knowledge about the cornea and anterior
Yeah.
seg disease?
So that's a good question. I don't know that there's anything that's kind of like a specific corneal one, but in Canada, the Sally Letson Symposium is
Mhm.
hosted in Ottawa, and every year it's between ophthalmology and optometry kind of collaboration, mostly ophthalmology that teaches it. But they pick one topic and they just do a deep dive. And I
Hmm.
went to the cornea one actually a couple years ago and learned so much. I learned more than I did in my fellowship. And so things like that, you kind of want to get after that. Going to really any like SECO Academy,
Yeah.
like there's lots of them, but these big ones that have a big collection of them and just picking all the cornea ones and going to
Yeah.
that'll get you on track. That'll at least get you up to speed on what's current knowledge, and you
Hmm.
might kind of what's coming as well too. But nothing replaces seeing it. And so I would
Yeah.
say if you're looking to try to do it outside of having sort of that formal training, you got to get into a clinic and shadow. Like pick
Yeah.
a
Yeah. For
ophthalmologist,
sure.
optometrist who's doing what you're trying to learn. If it's cornea and you're in Calgary, come and see me. But you just got to see them. You just got to see the volume. You got to see the crazy cases and listen through the clinical reasoning. That's the best way.
Modern optometry would be a great one because they issue different topics on their magazines and their blog articles every quarter or so.
Yeah.
So they have a huge cornea anterior segment disease
Mhm.
section where they have tons of articles on just that. And then the Mod Live conference,
Mhm.
Deepon and I went to one in Nashville. They have
Yeah.
that every year too in
Yeah.
September.
Yeah.
And most of the time it's in Nashville. I don't know if it's really going to change. It's
Hmm.
super fun. You get a lot of drinks there, which is fun. But yeah, they always talk about like any new medications that are, used on the cornea, especially for the States. Anyone living in the States, go. Anyone
Yeah.
in Canada, you can go and then cry when you get home because none of the cool technology and
Yeah.
medication is available yet, but at
Yeah.
least you'll know about it before your other Canadian
Yeah.
colleagues will.
Yes. Yeah.
So those are pretty good resources too that I'd recommend,
Yeah.
especially the mod optometry articles. I do like those because
Yeah. Those are
they're
really
written
good.
in a more
Also,
like
I think,
digestible form and
and
they're
and
cool
Deepan,
cases.
yeah, and Deepan, you're an author for Eyes On, I think, right? And so those
We
are
both
those
are.
are
Yeah,
really good.
we
Oh,
both
Yeah,
are.
perfect.
yeah.
Okay,
Eyes
yeah,
on Eye Care too is
yeah,
a
that's a
great
really
one.
good one.
Yeah,
And
same with
you contributed
review
on
of
the podcast.
optometry. That
Yep.
would be a
Yeah.
good one too, because then there's also CE, like CE
Yeah.
content for cornea stuff for you to
Yeah.
test your knowledge.
Yeah.
But yeah, thank you so much, Sophia. We really appreciate you sharing a kind of a snippet of a day in the life of a cornea specialist and knowing your journey. Like it sounds intense and it sounds crazy seeing that many patients a day, but it
It is.
definitely sounds like it's a rewarding
Yeah.
career and like a rewarding journey for you.
It
So
is.
I'm happy for you for that.
Yeah. Thank
I'm
you.
happy for you to
Yeah.
be in the cornea zone because I never go there.
Yeah.
We are going to cut off this episode short. So for anyone listening, there is actually going to be a part two because we really want to pick Sophia's brain a lot more, but everyone's attention span is definitely not long enough to listen to
Yeah.
like a 2 hour episode.
Yeah.
So Sophia earlier was going into how to approach the cornea, kind of step by step. How would you know where something is and what layer of the cornea? When would it be an emergency? When is it not? How to handle it? And we're actually going to save all of those tidbits for part two. that's going to come out next time. So for now, we're going to wrap it up. And then, yeah, everyone can look forward to listening to the next part if they're not cornea experts like me and they want to learn more just so that they save their patient from going blind when they're doing primary care.
Thanks for listening to Four Eyes, the podcast series brought to you by Young OD Connect. Be sure to subscribe and follow us on Instagram or YouTube at Four Eyes Optom for more content. We'll see you guys next time. Bye.